Bismillahirrahmanirrahim. Diabetes mellitus in the pregnant woman. So there are two types of diabetes when you discuss about the pregnant woman. Either it's a gestational diabetes, mean the woman was not the diabetic before pregnancy. This diabetes developed during the pregnancy. Other is the pre-existing diabetes or over diabetes mellitus, mean the before the conception the woman was the diabetic. So it's either it's a type 1, mean it's insulin dependent diabetes mellitus, or it's a non-insulin dependent diabetes mellitus. Okay, so this occur in the later life, it's occur in the early life. So if you look at the diabetes, it's occur in 2 to 5% of pregnancies, and 57% are due to gestational diabetes. Okay, and 7.5% type 1 diabetes, and 5% type 2. If a woman develop the gestational diabetes, there are 50% chance of developing the diabetes mellitus after the delivery. Okay. And if there is a diabetes in the pregnancy, it's alarming condition, because it's there are a lot of risk for the woman and a lot of risk for the fetus. So if you look at the with diabetes is more complicating is it's a pre-existing diabetes. Pre-existing cause a lot of complication. If you look at here, so this is list of complication which occur in the woman and the fetus: miscarriage, congenital malformation, preterm stillbirth. So we come back to this complication later. First we cover the diabetes. So as I mentioned, two types. And what are the risk factor? Old age or multipara. It's a risk, increase the risk of the diabetes. Okay, and if it's a history of the any complication in the previous the pregnancy, for example, if it's a intrauterine fetal death, or a history of congenital anomalies to the fetus in the previous pregnancies. Okay, so it's increased the diabetes risk in this pregnancy. Okay, so if there is a history of congenital anomalies or any the complicated history of pregnancy. Okay, so this increase the risk of diabetes. Okay. Pathophysiology, what is the pregnancy is actually a diabetogenic condition, mean the diabetes work against the insulin, because the placental hormones, for example, progesterone, cortisol, HPL, human placental lactogen, they are working against the insulin, and other also insulinase enzyme which are also destroying the insulin. So these all lead to the diabetes. Okay. What investigation you do in this mother and for the fetus? So maternal to confirm the diagnosis, and fetal to check out the anomalies. So in the maternal, so all the pregnant ladies between 24 to 28 weeks should be tested for the diabetes. So by giving the 50-gram oral glucose tolerance, it's a oral glucose tolerance. If it's more than 140, mean it's a diabetic. So and other diagnostic criteria, which is 3 hours. 100-gram oral glucose tolerance test. So you can look at least 4 values, and if 2 are abnormal, so it's the mean diabetic. Okay, so first is the fasting blood sugar, mean if it's more than 90, it's the diagnostic criteria, and 1 hour if it's more than 165, at 2 hour if it's more than 145, at 3 hour if it's more than 125. So if in any of two values are abnormal, so mean it's a diabetic, gestational diabetes. Okay, so you can check out the HbA1c, because it's give the data of 3 months. So it's best indicator for the occurrence of the fetal congenital anomalies. Okay, so to check out the fetal anomaly, you go for the ultrasound at the second trimester for anomalies again, and the third trimester for macrosomia or polyhydramnion. Okay, and also assess the fetal well-being. So because it's important to check out the fetal growth, what's going on with the fetus due to diabetes. Okay. So if it's a diabetic, how you treat? Treatment option is if it's the blood sugar is less than 200, you can suggest the diet and exercise. Diet mean remove all the sugar from the diet. No, the refined sugar or any sweets like in the chocolates or biscuit type. So stop this diet and also ask the patient for the exercise or walking or and gym, whatever the easier. Okay, and they continue metformin if it's already given, and if it's blood glucose is more than 200, then go for the insulin 2/3 dose at the morning and 1/3 dose at the night, especially 50-50 regular NPH. Okay, and avoid the oral hypoglycemic. Why avoid oral hypoglycemic? Because most of them are the teratogenic and they are long acting. If they are long acting, it's difficult to control. So that's why avoid the oral hypoglycemic. Okay, metformin you can give it, and otherwise insulin is a better choice. Okay, go for the delivery. If it's a good control, wait for the what about the delivery? What about the delivery? If it's a good control over the glucose, then wait for the spontaneous labor pain. If it's a poor control, terminate the pregnancy and also give steroid for the lung maturity. Okay. So So why these a lot of anomalies are occurring? This is all due to insulin. Why insulin? Let's look at it. Here is a mother, here is a fetus. So if there is high glucose, in the diabetes, where is high glucose or mother is hyperglycemic, this glucose enter into the fetus. This stimulate what? Insulin. So this high insulin, which insulin is what? Insulin is anabolic. So there are a lot of problems associated with the insulin. Number one is the macrosomia and organomegaly, which cause what? Which causes shoulder dystocia or birth injuries. Okay. High insulin also causes the polycythemia. Polycythemia means high level of blood, RBC. Why this is? Because there is a high level of the erythropoietin due to renal injuries. Okay, so this causes the hyperbilirubinemia because more RBC, more destruction, more hemolysis that will increase the bilirubin, which cause the jaundice. Okay, so hypoglycemia, it's not during the pregnancy, but after the pregnancy, when the fetus is delivered or the baby is delivered, what will happen? There is a hypoglycemia due to high insulin. That's why IV glucose should be given. Okay, hypoglycemia cause what? This cause the hypomagnesemia, hypocalcemia. Why? Because hypoglycemia. Because there is solute in the renal. If its solute is present in the renal, what they call, for example, here is a kidney. So if the solute is present here, so this will attract the other solute, magnesium, which the magnesium also excrete. So this will cause the excretion of magnesium, cause what? Hypomagnesemia. Okay, so when there is hypomagnesemia, so this is stimulate the parathyroid to maintain the magnesium. So they also lose the calcium to maintain the magnesium. So this will lead to hypomagnesemia as well as hypocalcemia. Okay, there is the RDS, respiratory distress syndrome. This is RDS because high level of insulin also intervene the maturation of the lungs, or you can say surfactant development. Okay, so this stop the surfactant. Okay, so that's why there are respiratory distress syndrome, and gestational hypertension is secondary to the diabetes. Okay, so gestational hypertension, which can cause the preeclampsia, mean hypertension plus proteinuria. Okay, So maternal complication, we have fetal complication and the neonatal. Maternal complication, number one is the gestational hypertension, preeclampsia. Other are the pathies, neuropathy, retinopathy, nephropathy, vasculopathy. This is all associated with the high level of glucose, and they are damaging the nervous system, retina, nephron, vasculopathy. So these are the more prone to the injury. So that's why it's common in the diabetic mother. Okay, and the thromboembolic diseases and the the risk of infection, especially vulvovaginitis, abortion, preterm, pre-rupture of membrane, pre-rupture of membrane, amniotic membrane. Okay, and peripheral sepsis or diabetic ketoacidosis, pulmonary embolism. So these all are in a series. Okay, instrumental deliveries because of the polyhydramnion or macrosomia. Okay, what are the fetal complications? Three important complications you must remember: cardiac defect. Okay, especially VSD, ASD. VSD is most common, especially here is the ASD. Okay, cardiac defect. And the other is neural tube defect. What is the example? Spina bifida is good example. Okay, where you can see here. Okay, and the other is sacral aging. Sacral means the last segment of the vertebra is not developed. You can see here, this is the vertebra, and you can see this. There is a agenesis of the sacral caudal regression syndrome. Okay, so you can see here, limb is not developed. Okay, so and macrosomia, polyhydramnion, these are other, but these three are more common. Fetal birth injuries, shoulder dystocia, sudden intrauterine fetal death, neonatal complication, RDS, and the hypoglycemia, hypomagnesemia, hypocalcemia, polycythemia, hyperbilirubinemia. In this picture, you can see the macrosomic big baby, and here shoulder dystocia, meaning the shoulder is behind the pelvic bone, respiratory distress syndrome, and you can see here look at the lung. If you see here, the immature lung. Okay, and if how these complications are happening, so this is actually summary of that. So if you look at high insulin, which is the anabolic and cause a macrosomia, mean big baby cause a shoulder dystocia, and also the perinatal asphyxia. This is due to the neck constriction of baby, and there is also other birth injuries can happen, and neonatal hypoglycemia, because before birth the baby is taking high glucose from mother, but after the birth there is stoppage of high glucose, which but insulin level is high, so this lead to neonatal hypoglycemia. Okay, and the RDS, need respiratory distress, because the high insulin also interfere the maturation of lung. Okay, if you look at on the mother side, where the insulin resistance in the mother herself have decreased ability to uptake glucose from blood. So because low glucose stimulate the catecholamine or a stress condition, which cause the vasoconstriction. So this if at the placenta, so it cause the hypoxia, fetal which cause increase the fetal erythropoietin. High level of the erythropoietin increase the blood cell development, so which is polycythemia, and mean more blood, more destruction, hemolysis, hyperbilirubinemia, which cause the jaundice. And if you look at on this side, throughout the body, causing hypertension, and at the kidney, causing glomerular leakage of protein, which cause a gestational hypertension, and the leakage of protein, which cause the preeclampsia. Okay, if because but there is hyperglycemia condition, because there is no uptake, but high glucose in the blood, so which cause glucosuria, mean the glucose is coming out of the urine, which can cause a bacteriuria, mean bacterial development. Okay, and high level of glucose followed by the hypomagnesemia, which is followed by the hypocalcemia due to parathyroid activation. Okay, and excessive glucose cause of the premature aging. Okay, and which cause a premature the placental cannot support fetus to full term. So that's why preterm or prematurity or fetal demise is common, and the intrauterine growth restriction or retardation is common. Okay, so this is summary of actually how the complication are occurring in the diabetes. So okay, so this is chart of the comparison for the gestational diabetes, type 1 diabetes and type 2 diabetes. Thank you very much. Allah Hafiz.